Our next speaker is Dr. Edward Ted Fitzsimons, who's Consultant Haematologist at Gart Naval Hospital, Glasgow, and Honorary Clinical Associate Professor at Glasgow School of Medicine. Ted's a great friend and ally to the Haemochromatosis Society, and has spoken at this conference in the past and also at our Patient Information Days in Glasgow. He also chaired our medical conference brilliantly yesterday, keeping the flow going. He has a career-long interest in iron metabolism and is going to talk to us today on the subject of hematology and hemochromatosis.
Thank you very much for asking me to speak today. I'm really going to describe some of the efforts we're making in the west of Scotland to improve the early diagnosis in hemochromatosis. But before I do that, I'm going to give you a wee summary about iron and run over some of the things that Professor Claude Brissot discussed this morning. So, why do we need iron? Well, we need iron for these chaps, and these are our red cells. And our red cells are full of iron, okay? Most of the iron in our body is in our hemoglobin and circulating within our red cells. Now, not everyone is of the opinion that they need iron for their red cells. Arnold Schwarzenegger, of course, thinks that pumping iron allows him to be the governor of California. And why are hematologists involved? Well, hematologists are involved because, of course, the best treatment, the easiest treatment for hemochromatosis is venesection. And removing 500 mils, removing a pint of whole blood, effectively gets rid of between 200 and 250 milligrams of iron in 10 to 15 minutes. So that, once you have venesected 20 units of blood, you've lost something in the order of 4 to 5 grams of iron. Now, before we go on to the rest of the talk, can I just go over just some of the terms that you heard this morning? Maybe familiar, but just let me go over them again. So transferrin. Transferrin is the protein in our plasma that will carry iron. Ferritin. Ferritin is the protein that stores our iron, and it stores our iron safely and in a form that's readily accessible. So the bone marrow, the red cells, can take the iron from the ferritin and use it to make hemoglobin. Ferritin is usually inside the cell, but a tiny amount of ferritin escapes into the plasma or into the serum, and we call that serum ferritin. And I think most people in the audience will have had serum ferritin measured more than once. Now, the important thing about the serum ferritin is that generally, the level of ferritin in serum relates directly to the amount of iron in the body. The other term that we need to discuss is the hormone hepcidin, and it's easiest just to think of hepcidin as low iron hormone. Now, what about transferrin and transferrin saturation? Well, normally, transferrin is a molecule that has 2 iron binding sites. Normally, in our serum, here is our iron. Normally, in our serum, our transferrin is about 30% saturated with iron. So it's 70% not saturated. In iron deficiency anemia, the commonest anemia in the world, we see we've got less iron, and in response to less iron, the liver will make more transferrin. So you get more transferrin, you get less iron, and you get low saturation. Normal saturation, about 30% with iron. In iron deficiency, it's low, it's less than 15%. Now, in hemochromatosis, the liver senses that we've got a lot of iron, and in response to a lot of iron, it makes a bit less transferrin. The iron will saturate the transferrin such that, in fact, you may use up all the transferrin binding sites. There may be some free iron in the plasma, and we call this free iron non-transferrin bound iron. And this iron is metabolically unstable and highly toxic. What about serum ferritin? Serum ferritin is a very useful measurement. It's reduced in iron overload, in iron deficiency, and it's increased in iron overload. Now, there are some complicating factors. You can get ferritin is what we call an acute phase protein. So it can be raised by factors other than iron. So we see it raised in the metabolic syndrome. We see it raised in patients who have got tissue inflammation. And we can see it raised in patients with a variety of liver problems. Why is serum ferritin important to me? Well, I measure it in my lab, and hematology labs measure serum ferritin. Now, how does the whole thing hang together? Now, normally, the body will contain 4 grams of iron, and iron in the body is locked in the body. It's one of these unusual compounds in the body where the level is determined by the amount we absorb, not the amount we get rid of. Effectively, once we've got iron on board, it's very hard to get rid of. So we have our, normally, normal circumstances, we have our 4 grams of iron. From our bowel, we require only to absorb something between 1 and 2 milligrams a day to stay in iron balance. And the absorption of iron from the bowel is controlled by this hormone, hepcidin. Once iron is in the body, it's bound to transferrin, and the transferrin will take it to the bone marrow to make red cells, take it to the liver, take it to the muscles, take it to a whole variety of enzymes. Our red cells last for 120 days, and we don't lose any red cells apart from women. Premenopausal women will lose between 1 to 2, effectively equivalent, 1 to 2 milligrams of iron a day as a result of menstrual blood loss. A pregnancy will cost a mum something like 500 milligrams of iron. The red cells are broken down in the spleen, and the iron from the red cells is released again to transferrin. And once again, the release of iron from the spleen is controlled by our hormone, our friend hepcidin. So hepcidin is regulating the iron we absorb and regulating the iron we release from our spleen that's destroyed old red blood cells. Let's put this a bit more simply. We've got 4 grams of iron, we've got 3 grams in our red cells, we've got 1 gram elsewhere, and by and large, to stay in iron balance, we only need to absorb 1 to 2 milligrams a day. So what goes wrong in hemochromatosis? Well, in hemochromatosis, the body iron content can be greatly increased. Let's take an example where the body iron content isn't 4 grams, but instead it's 20 grams. And why is it 20 grams? It's 20 grams because you've lost hepcidin. And without hepcidin, the absorption of iron from the bowel is not regulated. So instead of absorbing 1 or 2 milligrams of iron from the bowel, you'll absorb 4 to 5 milligrams a day. That iron will be bound to transferrin, taken to all the tissues that need it. The red cells that have taken it up will be eventually destroyed. And then the spleen will start to fill up with iron. And there again, the iron release from the spleen is controlled by hepcidin, which you have lost. And iron will come flooding out of the spleen, or what we call the reticuloendothelial system, and saturate transferrin. So you'll have high levels of iron and high levels of transferrin saturation. Let's put this simply. Here we are with it. Hemochromatosis, 20 grams of iron, still only 3 grams in the red cells. So 17 grams going to go elsewhere, to the tissues, we'll see the other the tissues that are affected in a minute. We're still only losing 1 milligram of iron a day, but during the course of the day, absorbing 4 to 5 milligrams. Now, this patient would undoubtedly be C2-8Y homozygous. Serum ferritin levels would be grossly elevated above 2,000, and transferrin saturation would be 100%, plus there might be some of this very toxic free iron, this non-transferrin bound iron. So what are the other tissues that might take this iron? Well, it can go to the liver and cause cirrhosis or liver damage in other forms. It can go to the pancreas and cause diabetes. It can go to the joints, cause arthritis. It could go to the skin and cause a bronzing color. Right. So I'm a hematologist and I practice in Glasgow. So why am I so interested in hemochromatosis? Well, it's because it is, of course, the Celtic curse. And Scotland, like Ireland, has a very high incidence of hemochromatosis. And this high incidence has got nothing to do, it has got nothing to do with our other favourite national drink. We know now that it has to do with our genes. And in the west of Scotland, in the Celtic population, about 1 in 6 to 1 in 8 Celts are carriers for hemochromatosis. So if 1 in 8 are carriers for hemochromatosis, if there's a partnership between 2 carriers, there's a likelihood then that 1 in 4 of the children would have full hemochromatosis, 2 in 4 of the children would be carriers, and 1 in 4 would be normal. So it indicates that while we have 1 in 8 Celts that are carriers in Scotland, we would predict that we've got between 1 in 200 and 1 in 300 homozygotes, Scots that are genetically at risk for developing hemochromatosis. And this figure is far, far greater than the number of cases that we have identified. So my interest in trying to promote early diagnosis. Always at this point, a good time to introduce a celebrity patient, a celebrity Celt. Now, you might well think that this chap, if you don't know, he's Ed Sheeran, or Sheeran, Ed somebody. Got very Celtic features, but this is not my patient. This is my patient. And this is Robin Galloway, who supported the Haemochromatosis Society in Glasgow. And Robin is the morning radio presenter for Heart Radio. And Robin had presented with hemochromatosis some years ago, and he's a difficult patient because he's one of those group of patients that we talked about where I can get his ferritin down to 30 or 40, but he'll still run a transferrin saturation of 95%. So in actual fact, Robin himself chooses to run a little bit iron deficient. And he's happy with that, I'm happy with that, and so is his transferrin saturation. So how are we going to try and improve the early diagnosis? So there are thousands out there who are genetically predisposed to hemochromatosis that we have not yet identified. So how can we do this? And our idea is to try and use serum ferritin. Use serum ferritin more. Serum ferritin is one of the most commonly requested laboratory tests from general practice. We perform something like 70,000 serum ferritin requests in Glasgow and Clyde. We perform 70,000 serum ferritin requests from primary care each year. And general practitioners know very well what to do with a low serum ferritin. There is only one cause of a low serum ferritin. You've got iron deficiency. There's no other cause. So it's well established what to do with a low serum ferritin, but there is in fact no management plan whatsoever for raised serum ferritin values. So we carried out a pilot study just to see what are serum ferritin values like from patients in primary care. These are not samples that we have instituted. We've not asked for them to come. These are samples that have been sent in from primary care. Now, I've actually given you the publication here because it is actually the only publication I've ever done with my daughter, Katie Fitzsimons. And I did it. She was a final year medical student, and I was kind of hoping that I could convince her in the merits of hematology and iron interest, iron metabolism. Katie's now an anaesthetist in Melbourne. So what did we find when we looked at serum ferritin samples being taken in primary care? Well, look at the men. Now, we only looked at people over the age of 30 because hemochromatosis seldom presents before 30. So we looked at a patient group over 30. And what we could see was that the normal upper limit for ferritin in men is 300. And what we saw is that irrespective of age, in the group 30 to 50, 50 to 70, and over 70, almost 20% of our samples were coming with raised serum ferritins. It was a slightly different picture in women. In women, the upper limit of normal is generally 200. When we looked at the same age population, we could see a definite age effect. Women between 30 and 50, there were only less than 2% had ferritin values of more than 3% had ferritin values more than 200. This increased to, the percentages are, where are the percentages? Yeah, there's 7%, 10% between the ages of 50 and 70, and by the time the patients are 70, then you're getting to the sort of same percentage as men. 17, almost 20% of women over the age of 70 have got raised serum ferritin. So these are just patients that we have not selected. These are samples being sent in from primary care. Now, the other interesting thing from these samples was that we looked at something like 4,000 consecutive samples. And from those 4,000 consecutive samples, there were 56 that had serum ferritin values of more than 1,000, so markedly elevated serum ferritin values. What was alarming is that when we got these patients' case records, 32 of these patients had high ferritin values that were unexplained. So it's clear that we are seeing a lot of samples, serum ferritin requests from primary care. If you look at patients only over the age of 30, it's 30,000 per year. In total, we're getting 70,000 per year, but patients over the age of 30, 30,000 per year. GPs are clearly using this to look for iron deficiency. They know what to do with a low serum ferritin. And we found that 20% of males at all ages had raised serum ferritin, and between 3 and 17% of women, it was age dependent, had raised serum ferritin. What we also found was that 50% of grossly elevated serum ferritin values were not explained. So it seemed to us pretty clear that GPs are uncertain as to what to do with raised serum ferritin values. And although we may call it the Celtic curse, it is perhaps better thought of as the silent curse. Because as I say, if there are between 1 in 200 and 1 in 300 Celts in Scotland at risk, it indicates that for every one patient diagnosed, there must be something like 10 out there that are not diagnosed. And the same applies in England. So there's a big missed population. So what did we do? Then, in an effort to try and improve the early diagnosis, we looked again at something like 4,000 patients whose blood had been sent in by primary care. So these are samples that we have never asked for. These are samples that were coming in from primary care. And we got ethical approval that if the ferritin value was raised, we would automatically check transferrin saturation. And if transferrin saturation was raised, we would automatically check for the HFE gene. So there have been other studies to try and help early diagnosis, big studies. The HARE study from North America looked at something like 100,000 patients. The Scripps-Kaiser study from California looked at something like 30,000 patients. And the Melbourne study looked at something like 30,000 patients. Now, these patient groups are different from the patient group that we looked at. These studies are all volunteers. And they are different to the samples that we're seeing sent in from primary care, from general practitioners. Where we see a lot of samples coming in with high serum ferritins, over 1,000, amongst 100,000 patients in the HARE study, there are only 360 with raised serum ferritins. So the samples that we get from primary care are different to the samples you will see in volunteer studies. And what did we find? What did we find? We found that, we found that the major cause of raised serum ferritin was not hemochromatosis. 80% of patients with raised serum ferritin didn't have hemochromatosis. And that actually even applied to very high serum ferritins. If serum ferritins is more than 1,000, 1 in 5 males with a ferritin of more than 1,000 will have hemochromatosis, but only 1 in 10 females would have it. The far more common cause of serum ferritins over 1,000 was alcohol abuse, metabolic syndrome, or cancer. So from our study, we developed an algorithm which we're trying to get the Scottish Health Department to introduce. If you're over the age of 30 and sample has been sent in by your general practitioner, if the ferritin is more than 200 and the transferrin saturation is more than 40%, you've got a 16% chance of having hemochromatosis. In males, if the ferritin is more than 300 and the transferrin saturation more than 50%, there's an 18% risk of being hemochromatotic. Now, you know that unselected population screening for hemochromatosis is not going to be accepted. What has been accepted is that high-risk patients should be screened. And what's the best established way of doing that is family screening. Once there is an index case, family members should be screened. And in most cases, a family member will result from the partnership of two carriers. And if two carriers are together, they would have a 25% risk of producing hemochromatotic children. 25% is not a great deal higher than the 16% and 18% that we found with our study. So that is something that we are going on to try and challenge the health service in Scotland to take on. Reflex screening of samples coming in from primary care, high ferritins, they would automatically get a transferrin saturation raised, they would automatically get the gene test. If this algorithm was introduced in Scotland, it would predict for us recognizing 800 new cases per year. And that number would be further increased by family studies from the index case and identifying other family members. So that's where we are at the minute. Now, sorry, I thought it was being read for a wee while. Just to finish up, if you live in Scotland or Ireland, you'll know that there's no such word as Celtic. You're either Celtic or you're Rangers. And I definitely have green genes. I don't have hemochromatosis genes, but I definitely have green genes. I'm a Celtic man. And that is and 50 years ago, Celtic won the European Cup. And that is the stadium where Celtic won the European Cup in Lisbon, which I visited and paid homage to. So how can I get? I don't like the idea of this being called the Celtic or Celtic curse. So how did I plan my revenge? Well, I had a patient present once with swollen glands. And I didn't understand what was the cause of the swollen gland, so I got one of my surgical colleagues to take it out. And the swollen gland, was full of tattoo ink. So, and I found out that tattoos can cause your glands to swell. This chap was covered in tattoos, okay? But this was the one I blamed. This was the one I blamed. That is the Rangers sign. And we wrote this up in the journal. We called it Glasgow Rangers lymphadenopathy. Now, I tell you, I have published a fair bit in my time, but there's no publication has ever had more feedback than this. And it had to do with the conclusion that we came to, was that they said that, so we concluded that although reactions could occur with any colour of ink, we suggested that the followers of another Glasgow football team might suggest that a green pigment would be far less likely to cause any unpleasant reaction. And my CV was greatly boosted when the Sun took it on. Thank you. So conclusions, my serious conclusions. Sorry. So the vast majority of patients in primary care with high serum ferritins don't have hemochromatosis. But if we were to introduce reflex testing of transferrin saturation on patients with raised serum ferritins, we could identify a population which has got almost a 20% risk of having hemochromatosis. And that's not far off the 25% risk that is accepted for family screening. The laboratory and the clinical burden of increased cases would be low. The cost would be low. And what we're doing now is trying our best to get this algorithm introduced and into action in areas where there's high prevalence of hemochromatosis. Thank you.